Bismillahirrahmanirrahim. Assalamu alaikum, everyone. My name is Nadiah Mohajir,
I am Kamilah Pickett. Assalamu alaikum.
and we are so excited to join you again today for the second in our series of conversations on looking at what building trust as a community and what health looks like in Muslim communities. Today, we're going to be talking and looking a little bit into what the history of communities of color, particularly Black and Indigenous communities, is with the healthcare system, and why communities of color, why research shows that communities of color have a history of delaying care. Last week, the last conversation that we had, we really looked at the following questions. We looked at, what does it look like to build trust in the community and the importance of approaching health in Muslim communities from an intersectional lens. So we're often talked about as one community, but given our diversity, it's important to uplift that we are many communities and that it's really important to think about working to create community-led interventions.
Exactly. And I am happy to be partnering with HEART. I am the director of the Community Health Compass, which is a health advocate training program that centers the experiences and needs of Black Muslim communities. And so last time we talked about why I chose that focus, and I think that this conversation was a natural follow-up to that, because it's important that we talk specifically about why the differences and health outcomes exist in different communities. And, to begin this conversation, we need to talk about what health equity is. So it is, for public health practitioners and researchers, health equity is the attainment of the highest level of health for all people. And to get to that goal, we have to eliminate avoidable health inequities and health disparities, those that require both short-term and long-term interventions. And the root of all of that is attention to those causes, and a particular attention to groups that experience obstacles to health associated either with their social economic disadvantages or historical and contemporary injustices. And I think that a lot of times, as communities, we're willing to see that socioeconomic factors play a part in health inequities and health disparities, but we don't really think about the contemporary, the historical injustices and also the contemporary injustices that also have an impact. And that's important because if we're designing interventions meant to focus on any one particular part of the population, we have to take that history into account. That's the only way to design something that will be successful and also respectful of where that community is and how it got there.
Absolutely. And, one of the images that we like to share is at HEART is really just showing the relationship of, health inequities and health inequalities kind of being at the center of this Venn diagram with, a lot of these structural oppressions that you talked about. So the impact of structural oppression, structural gender-based violence, structural sexism and patriarchy, and then capitalism and how power and privilege, politics, all of that intersect with continuing to perpetuate certain inequities and why certain communities continue to experience disparities in their health outcomes, even when you control for example, age or socioeconomic status or whatever. There's still a difference. And all of that cannot be attributed to anything other than some of these historical traumas and historical structural oppressions that have been sort of taking and it have been making an impact on the communities as a whole. And so I think it's really important to, as you said, to sort of address all of those in the intervention that you are trying to think about.
Right, because history is foundation, right? It has set the groundwork for where we are now. And even now, when we're having really important conversations leading up to the next election cycle and, conversations based on things that are happening legislatively, we have to think about, what what an equitable healthcare system looks like. And in order to imagine that, envision that, we have to take that history into account, right? Because even, there is no such thing as a one-size-fits-all health intervention. It doesn't exist, because you may improve outcomes for an entire group. Like if we're focusing specifically on women, you may improve outcomes for all women and still have a gap, a disparity gap between, Black women and white women, or Asian women and white women. And so you have to have really specific interventions that are designed, one, for improvement, but also to close those gaps. So I think it's important to note that even now, when we're listening to conversations about healthcare, like Medicare for all, right, or people are posing platforms, we should really think about, are these solutions that are going to improve the health of everybody? And are they specifically going to close gaps that exist based on race and ethnicity, not just income, because income is not a proxy for race and ethnicity. So that's my little spiel before we get deeper into our original topic, because it's important, right?
Absolutely. And I think it's also important to challenge how, a lot of this research and these interventions are done in the first place, right? If you look at, you do a literature review of, X issue. So whether you're looking at cardiac health outcomes, or you're looking at, I don't know, some other sort of outcome, it's, when you do that, it's really hard to find research that are studies that are done on communities of color. And then on top of it, taking it one step further, studies that are done on specific, cultural or racial communities. So Black communities, Asian communities, Arab communities, et cetera. And then oftentimes those studies have limitations. And just looking at some of the large, well-known studies, you will see a pattern that is, they're lacking in representation, both when it comes to gender representation and when it comes to racial representation. And, some of the larger studies that have been done that have targeted communities of color, they have also been extremely unethical and had some problematic pieces of mistreatment towards their study participants. And so I think, just even looking at at large at all of the studies that have been done, and just seeing that disparity in and of itself, of the fact that there is not enough representation, there is not enough, especially with the large studies. There's the large studies with, less limitations. The biggest limitation is that there is no representation. And that is important when you're thinking about health outcomes. And when you do research, it's across the board. There are disparities across the board, whether you're talking about cardiac health, or you're talking about mental health outcomes, or you're talking about maternal health outcomes. There is a disparity across the board when it comes to comparing white participants to communities of color, and in particular Black communities.
Right. And it's not that we are advocating for experimentation, right? Like, I'm not saying that yes, please come and study us more. No, that is not what I'm getting at. The point is, though, that these large scale kind of public health focused studies translate into policy, and to how, dollars are allocated for any specific health issue. They even underlie how treatment is given to patients. And so when you think about how research becomes policy, becomes practice, then it is important that, different groups are represented in a way that is ethical, and in a way that is helpful and with their full consent, right? Because even like a popular topic of conversation now is like the opioid abuse epidemic. Well, what happens then when those studies or that conversation centers only one specific segment of the population? Well, then policy is made. And so then you end up with a a disrepresentation of who is really impacted and what happens on the ground in a doctor's office when a patient comes in and they need either pain management or something happens, right? And if your focus of the study has been on white patients in Appalachia, then that doesn't really, cover like populations in an urban area that happen to be Black or Latinx, or Asian, and their interactions with their healthcare provider. So that's why it's important. But then we also have to note that there is no sphere of American medicine that has not been touched by the research and the use of research of Black bodies. And that was true during periods of enslavement and afterwards. Beginning, at the very idea of this country, Indigenous people were either displaced or massacred or researched on. And the same happened to enslaved Africans. So whenever there were experiments that new medicine that were intended to benefit, white people, they experimented on Indigenous people or enslaved African people first. And that continued throughout history. So patients from poor and marginalized communities didn't receive the same ethical considerations as their counterparts. When you had Black patients being relegated to like Black wards in hospitals, they were disproportionately affected. And we see that in like stories or that people know, like the Tuskegee experiment, which was a 40-year-long study that was supposed to be for, basically it was men who had never had syphilis were never told or treated, right? That's one story that I think most Black people know. Even if they don't know the details, they know the name and kind of the consequences of it. But that's just one, right? There are others.
Yeah. And I mean, with regards to Tuskegee, I mean, from the study design to the implementation, all of it was so flawed, right? Like even when, to your point about full consent, it was never there. They were told that the study was only going to last 6 months, and it ended up lasting 40 years. And, the fact that the purpose of it was flawed, right? To see what happens when you don't treat syphilis. So as a result, there was a decision, a very intentional decision made on the part of the investigators who were doing this study to say, we're gonna recruit participants in this study, some of whom have syphilis, some of whom don't, but we won't tell either party. And that in and of itself is flawed and extremely unethical, because during this 40-year time period, there was a treatment that was developed, which was penicillin. And, the fact that these study participants did not have access to get better, to get this treatment, was in and of itself so highly unethical. And in fact, this study in particular has made it to at least my public health program, where we did study that. And, we did kind of take apart all of the different flaws of the study of why it was so unethical. But I'm not sure if it's made it to all of the different schools of public health.
I studied it, and I think, even if practitioners don't know about it, which is a serious problem, right?
Yes.
Like health practitioners should definitely know about this. But even if they don't, their patients do. Mm-hmm. Like I said, even if people don't know the particulars or the in and out, they know of it, and the trauma of it lingers. And so people are rightfully spooked when it comes to, participating in studies, because why would you trust that, it is going to, one, do what it says it's going to do, or two, be beneficial to you in any sort of way. And not just be beneficial, but it might not even be neutral. It could be harmful. And that's not the purpose, or not supposed to be the purpose of things like that. But bringing our conversation back to where this impacts women in particular, there is the story of Henrietta Lacks.
Mm-hmm.
Right? She is the cells from her cervical cancer have laid the foundation for so much research today, right? Like, medical history owes so much to this woman who did not in any way consent to be used in that manner. Mm-hmm. And had been used for decades and decades and decades. She contributed to like modern medicine's most important breakthroughs, like the polio vaccine, right? And she's never given credit for that because it wasn't intended to be a credit thing. She was, in their view, just another Black body that was being used for experimentation. And her story came to light when her family found out, and they pursued a case against the people who had done it. So, these are the sorts of things that happen, and they're the ones that we know about. They're the most famous ones, the most talked about. And then you think about all of the people that were experimented on that nobody ever mentioned or mentions, right? We know that a lot of modern gynecological procedures were first tried out on, enslaved women. These are procedures that are still used today, right? And then they were done without the benefit of anesthesia because it was like, well, who cares if they suffer tremendous pain while we're figuring out this thing, that is still the basis of how women are examined today. So those are very deep historical traumas that color how Black people, how Latinx people, how Asian people interact with the healthcare system, but women in particular. Mm-hmm. Because if you have the experience of your body being treated as a commodity, then it's hard to trust that anyone other than you will value it as intended.
And I think a lot of that historical context is informing the healthcare providers today and the implicit biases that they walk into every day into their exam rooms, right? And why is it that there are research study after research study showing that doctors are more likely to dismiss women and their pain, and especially Black women and their pain when they come into the doctor's office. That's just a part of being a woman, or that's just menstruation, or that's just, and why is it that keeps happening? And it's because of this deep historical context that has kind of paved the way for people to make assumptions about Black bodies and Black women. And, they don't need, they're resilient, they're strong. They don't need anesthesia. They don't need pain management because they're resilient. And I think that is extremely problematic, as women, seek help for, reproductive health issues such as endometriosis and polycystic ovary syndrome, or maternal health outcomes afterwards where they're not feeling well, or they're knowing something in their body is going wrong and they're not being believed. Another example that where that shows that that it's not about class or fame, right, is the example of Serena Williams and how she gave birth, and 2 days later or whatever, she was feeling it because she knew her body, and almost died, not getting the help that she needed. And so it's not even about having that access, and she was in a hospital, right? And she still was not being taken seriously. And I think that is an important indication of that implicit bias is just so real and so ingrained in the way healthcare practitioners think about healthcare delivery.
But it's not, to broaden it, it's not just healthcare practitioners. So in the last conversation, we were talking about like health as a community concept, right? And how it impacts every aspect of our life. So just like our health is impacted by everything happening around us, so is healthcare policy. It is impacted by culture. It is impacted by like the particular time that we find ourselves in. All of these things get translated into policy. And sometimes, you know, the implicit bias of practitioners definitely plays a huge part in how women of color are treated when we go to the doctor or when we have experiences in the healthcare system. But those stereotypes that we see, you know, everything from how we present our bodies to how we move through the world, right? Sometimes we internalize those things. So we get messages that say, you know, Black women are supposed to be strong, right? We're these like matriarchs, like we're elephants instead of women, right? Like, you know, we're supposed to be these unmovable forces, so that sometimes it's not just that the doctor is telling you that you're not in pain, that you are not accepting that the pain you're having is unusual, right? Or you know, not, I mean, when you feel it, if you have some, you know, if you have endometriosis or PCOS and every month, you know, you're curled up in a ball on the floor, it's not that you don't feel the pain, but you probably have been inundated with messages that say that it's okay to feel it, right? That it is nothing abnormal. And if you hear stories about, you know, your friends and, you know, your mother or the women in your family who've all had to deal with, you know, this kind of excruciating pain on a monthly basis, then you're led to believe that, well, this is just part of being a woman. And it never dawns on you, well, maybe we all have something, right? Like maybe we all have fibroids, which is likely the case, you know, particularly in Black women. It could be the case that, you know, your mother and your grandmother and your aunt and your friend, you all have fibroids, right? You all have, you know, some level of endometriosis, because those things are, you know, genetic, they're familial, right? But if you have not been given messages that it's okay for you to question a healthcare provider when they give you, you know, a diagnosis, or when they give you a treatment plan, or if you have been led to believe that showing any sign of weakness is complaining, right? It's not. There's a difference between, you know, other people are able to go to the doctor and seek care and seek opinions and not, you know, be labeled as aggressive or not be labeled as non-compliant, right? There are all of these messages that are both external and kind of internal, and it all makes this kind of funky soup that dictates how we experience healthcare. And it, you know, we have as women, we have the unfortunate reality of having everything about our bodies be dictated by policy, right? What we wear, and it starts very young, like what we wear, how we are able to, you know, access any part of healthcare, birth control, abortion, any part of reproductive healthcare, right? Like, we pay more for our healthcare as women. It is more highly regulated than healthcare for men. And it is a topic of conversation that everybody feels, you know, okay with having, and not always the voices that need to be heard.
Yeah, and you know, your point about the internal stories that are being told to each other as women, right? Like this is the way it's supposed to be, and this is how all of us experience this kind of pain, or this kind of bleeding, or this kind of you know, X experience. I think that's a really important sort of experience that happens among women, to build community and to build sisterhood. And I think it's actually a really important like point in time to actually think about interventions and think about, you know, okay, there is this really great community building that's happening. There's this sisterhood that's happening where women are sort of mentoring each other and holding space with each other on all of these different issues. And how can we actually use that to develop some sort of intervention or community education model that can help facilitate holding space with each other, but then also saying, okay, these are the red flags of when, there might be something wrong, and it might be more than just, what all women experience on a monthly basis and things like that.
Right. And having that conversation, but then also having solutions on hand. Because it's important that, we said that we hold space and that we talk about these things. And I fully believe that women do talk about these things. We're just amplifying conversations that happen, but then to have viable solutions for every stage of a condition is super important. And being able to access healthcare, whatever that means for you, is also important. And not, just that there is a place that you can go should you choose, but that there is a place you can go who will see you in a reasonable amount of time, who will treat you with respect and dignity, who will listen to your concerns and respond appropriately, and who will not bankrupt you while you're trying to handle all of that, right? And who will follow up with you, who will make sure that whatever, intervention they prescribe is actually one that will work for you, one that is feasible and viable for you, one that you can afford to do more than one time, right? So it's not just, you write a prescription or you tell a patient to do X, Y, and Z, and then you kind of like send them off and you never check again. Because we know as public health practitioners, what happens is people, if they can't afford, a medicine, or if they can't afford a therapy, or they can't afford to, come to your office once a week, then they'll just stop, and it's not that they don't value their health as much as you do. It's just that what you've given them as a solution isn't tenable. And so all of these things are important, and it's important that we as community members, as the sisterhood that we're trying to build, that we provide each other with these alternatives, right? And that we discuss that there are alternatives, that sometimes it's not an all or nothing. You don't have to just do one thing or nothing.
Absolutely.
That was important to me. And I think, for this conversation, why I think this series and this series of conversations that you and I are having is important, is, it is important for us to focus on, the things that might make us unique as Muslim women, right? There are certain religious beliefs that we share, not all of us, right? Because we know that the practice of Islam is wide and varied. And so, we can't agree on when the moon is sighted all the time. So we definitely are not going to agree on all things health related. Depending on which school of thought you follow or how you interpret things, it can be varied. There might be some things that are standard though, right? And so when healthcare practitioners design interventions for Muslims, right? They say, oh, I have a Muslim patient coming in. This means that she won't do X, Y, and Z, right? Or that I need to do A, B, and C kind of thing. What's important to me is that we not make Muslim an ethnicity. That, for Black Muslim women in particular, we have these intersecting identities. We've already talked about like the history. And so, Black Muslim women aren't just Muslim, they're also Black. And so we have this historical kind of trauma happening in this country when it comes to the healthcare system and medical interventions. And then we also have, religious obligations that we're trying to meet, or things that we're trying to do to stay true to our faith practice. So there's two things. But then, it's not just that, because we may also be immigrants, right? And have limited English proficiency or be undocumented. And all of these identities will color the way you interact with any state-involved system, including the healthcare system.
Absolutely. Absolutely. And I wonder if this would be a good segue into talking about, maternal mortality in particular in Black communities, and how, there's, a lot of appalling studies that are showing that, there is a very significant and statistically significant disparity between maternal outcomes for white women comparatively to Black women who are the same age, and it's something that researchers cannot explain in this moment. Like, they're not able to sort of find that connection of, like, why is that disparity still happening in 2019, and they've been following this disparity since, for decades now.
Right. And it's, and all of the things that, you would think, or researchers thought would be the solution, or things that would be like these controlling factors, like income level or education level, or even age of the mother at birth, they don't really account for where we're finding ourselves now, right? And you see more and more stories of, successful and, educated, wealthy Black women like Serena Williams having these really scary maternal outcomes. And not just her, there have been stories in the news recently about, a woman who goes in to give birth and she's had a relatively healthy pregnancy, and then something goes very wrong when she goes in to deliver, and, she doesn't leave the hospital. Her baby survived, but she doesn't. And this is not a person that doesn't have access to healthcare, right? So they've been having regular prenatal checkups. They've been, taking the vitamins and eating the healthy diet and doing everything that you are supposed to do, but their outcomes are different. And so then that suggests that a deeper look needs to be taken. That that the thing that is causing the concern is not income, and is not, medical compliance, that it is something specifically about their race and ethnicity that is causing this, right? And so if you have studies that don't take that into account, or that are not willing to concede that that is an issue, you never figure out what's going on, right? And in some of those cases, and some of the recent cases that have made the news anyway, family members have been able to say that, well, she was feeling really bad and she said something to her doctor, but they didn't listen. Mm-hmm. Right? Even in Serena Williams, that was the case where she said something initially and was kind of shooed off. And this is a woman who's paying private doctors, right?
Yep.
So if you can't get people who you're paying a lot of money to listen to you, then what happens to a person that is dependent on Medicaid, right? And they go into a hospital and are just kind of being pushed along. What happens then? And it shouldn't happen to anybody, regardless of your financial status. You should be able to go and give birth and receive the same level of treatment. Meaning you should leave the hospital healthy, and so should your baby, unless there is some sort of medical emergency. But just a normally proceeding birth shouldn't result in death. And so a huge part of that is practitioners taking more time to actually listen to patients when they register a complaint. And a lot of women have found ways around this, right? They use doulas. They develop relationships outside of a standard medical practice to kind of guide them through this process. And I think that that is something worthy of, even if you're not a woman that is giving birth, right? you have a way of ensuring that when you are having an interaction with a healthcare provider, that you're able to say what it is you need to say. So one of the classes that I teach is how to have an interaction with a healthcare provider, which seems very basic, right? But if you're never taught how to do that, why would you know? So not only how to make an appointment, but how to advocate for yourself once you get there. And, you know, the assumption is that if a person is normally outspoken in their everyday life, that they will be the same when they go to see their doctor. And that is usually never the case, right? Like, people feel intimidated or they feel rushed. And so they often don't, you know, tell like the whole history of how they're feeling, or why they're there. It's kind of like, I have 7 minutes for the doctor to see me, and, you know, he's going to say this, and that, and then I'm going to be out, right? And I've had experiences with that where I have to remember, like, wait a minute, Kamilah, you know these things. Like, why are you sitting here and letting this person like talk, and you're not advocating for yourself? So a lot of it is being able to advocate yourself and feeling as though you can do that you can ask questions, and you can, you know, demand that they pause for a minute. And that if you raise the concern, if you're not feeling well, you know your body, that you're able to say, no, seriously, I need you to stop and address this concern that I'm having. And I don't think that happens often enough. And it definitely is not happening often enough when, you know, women are going in to give birth, which is why we still have these huge disparities in maternal mortality outcomes.
Yeah, and I think to your point, I think, you know, power dynamic is plays a big role in how we're socialized as a society to sort of trust doctors. And, you know, the field of the profession of medicine is seen as something that is very prestigious and very, you know, and rightfully so. I mean, they have, you know, years and years and years of training and expertise. So of course they have achieved a level of expertise that is greater than, for example, you know, who may be in their office. But that being said, that lends to a power dynamic that can become very unequal and lend to things like feeling intimidated by the doctor, or even just being socialized to trust whatever the doctor says. Doctor knows best, right? Kind of like that attitude. A lot of communities are sort of socialized to walk into the doctor's office. And then we haven't even touched upon, you know, how health is viewed in different communities, whether we're talking, especially communities of color, and, you know, gender dynamics there of like whether, you know, when women receive healthcare, maybe their partner may be in the room with them, and how that can also impact their ability to ask questions, or the doctor to receive them in a way that doesn't lend to further stereotyping and further assumptions that are being made about, you know, the man kind of taking the lead on his partner's healthcare. It may not necessarily be a negative thing, and oftentimes healthcare providers may just make an assumption that the man is sort of making choices for the woman and not giving her the agency to speak for herself. But in a lot of communities, that is welcome, and that is the sort of partnership that people like to have. Like, there are women who like to bring their partners in, and it's a partnership in decision making, and not just their that one person's agency. So that is also something that I feel that needs to be talked about, is that decision making is different in different communities.
Absolutely. And it's not for you know, the healthcare provider to make that decision. It's for the woman going to seek treatment.
Mm-hmm.
You know, I have had experiences where I go to a new doctor, or like have been to urgent care, and they will ask, you know, because they see me in a QMR, and they will ask, you know, well, isn't there like a male relative that's supposed to be in here with you? And I'm like, no, I sprained my foot. I can tell you that. I don't need anybody else in here with me. I've never had a medical appointment where there was a male that I needed a male to come with me, or there was a male in the room with me. It's like, I'm having this conversation with you. And so sometimes that happens, right? Like, because I am a visibly Muslim Black woman, and sometimes that is confusing to people, to medical doctors, right? Like, they have this stereotype of like what a Muslim woman is supposed to be like when she comes to get healthcare. And so, yeah, these are all things that we have to challenge and kind of push back on, and make sure that we are not falling into the same trap as Muslim practitioners, public health practitioners, right? That we are not falling into those same traps and saying, oh, well, this is what, Muslim women do when they go to the doctor. It's like, no, that might be what one group of Muslim women do, but that is definitely not, there isn't anything that you can say that fits across the board. For Black Muslim women and Latinx Muslim women and Asian Muslim women, like, we all have different histories with healthcare, and we all interact differently.
Absolutely. And I think, to move into the final piece of our conversation, just really thinking about how the intersection of gender and race can contribute to health disparities. I mean, we've talked about it a little bit, but just to go into a little bit more detail, there's research that shows that women are more likely to delay care for, specific reasons. And then there's also research that shows that communities of color are more likely to delay care. And then, of course, the intersection of women of color delaying care. And really, like, why is that happening? What is the phenomenon around that? And, I want to emphasize again, I mentioned this earlier, it's across disciplines, across health outcomes, whether we're talking about, heart attacks and, behaviors between men and women in terms of health seeking behaviors when they're feeling like there's a heart attack coming on, versus, mental health outcomes where, men seeking, therapists and psychiatrists at a quicker rate than women seeking therapists and psychiatrists, and also how they're treated once they actually seek that care, right? There are studies that show about women, how they're treated with respect to some of their mental health concerns, that the symptoms are showing up the same exact way as men symptoms may be showing up, but the treatments that both male and females are given are actually very different. And so that is also lends to certain questions about, like, why is that happening, and what disparities are showing up because of race and gender.
Right. And I think in terms of delaying care, there are a lot of different factors, right? Probably the most fundamental one is cost. Mm-hmm. So, healthcare is expensive. If you are uninsured, it is even more expensive. And it's kind of like the thing, like, it is expensive to be poor in this country. Everything costs you more, including healthcare. So that's one. And just the fact that women require more healthcare services and pay higher out-of-pocket expenses during their reproductive years than men do. It just costs more to be a woman and go to the doctor, period. But then there's also the fact that women are often caretakers. And so if you are responsible for, the care of children, or the care of parents or siblings, then it is more likely that you will put those people's care ahead of your own. And so you will make sure that they get, to the doctor when needed, or they get the checkups that they need. And you kind of put yourself to the back of the line when it comes to that. That is one cause. But then there is also just the very real, the pain of not being believed or dismissed. And so what I have heard a lot, working, doing the work that I do, and being a Black Muslim woman and having friends who are Black women and friends that are Black Muslim women, is that it is exhausting to go to the doctor and be told that nothing is wrong with you when you know that something is, wrong or off. and, having to feel like you're pushing against something that doesn't include you. At a certain point, you just stop, right? Or you figure out other ways to deal with it. And, you kind of take yourself out of that situation. And like I said, I know how to advocate for myself. I advocate for other people. But even I have had experiences where I will go to an appointment for one specific thing and my doctor brings up something else, right? And I'm like, that's not what I'm here for. Or that's not the issue that, is concerning me. And you're not addressing that at all. So I have left medical appointments feeling dejected and have had to take a second to gather myself and be like, wait a minute, I'm not willing to let this, be the end. But I know a lot of people that do. Right. And so that's part of it as well. So there are a lot of reasons why women and in particular, women of color delay getting care. And what we know is that leads to very serious outcomes, health outcomes, meaning things that could have been prevented are not. Things that could be caught early, like different types of cancer, breast cancer, or cervical cancer. We know that Black women in particular are more likely to be diagnosed at later stages of cancer than white women are. And I believe that's also true of Latinx and Asian women, that the diagnoses for certain cancers happens at a later stage. And that's because, of all of these barriers to having healthy interactions with the healthcare system. And that is why now there is more emphasis on looking at the consequences of historical trauma and how that impacts, the health of communities now. And so when I'm talking about historical trauma, I'm meaning complex and collective trauma like oppression and victimization that is experienced over time and across generations by a group of people who share an identity, an affiliation, or a circumstance. And so trauma-informed care is now more popular when it comes to mental health, but also physical health, right? And researchers and physicians are delving more into how that impacts the health that they see now, and what they can do to address that, right? And so that would tie in all of these things that we're talking about, the history that people know of how bodies were experimented on, during periods of enslavement and colonialization, and how that, translates now into what communities of color, Black communities feel about the healthcare system, right? Whether people trust vaccines, right? You can go, it does not take a very long search on YouTube to tell you all the many reasons why Black people should not get vaccines, or why Black people should not, be in favor of certain reproductive choices, because of the history, because of eugenics, because of forced sterilization, because of, the Tuskegee, and maybe, things being given to you in a syringe that could, kill you over time, right? So there are all of these things that I think the medical community has to contend with in order to provide services that are beneficial in the long run, and that are going to close disparities.
Absolutely. And, I think all of what you've mentioned is so nuanced and important to think about when we think about, healthcare. And I think, it's easier for communities and I guess countries, even when thinking about it from a macro lens, to really think about healthcare as a one size fits all, because we are thinking about populations, right? And it's easy to just say, this is how we're going to increase the mammogram screening rates in, all of our communities by having free mobile clinics, you know, kind of pop up in communities. And again, if that trust issue is not there, if that trust is not there, or that, you know, community building and relationship building hasn't been made, then you can have all the mobile free clinics you want.
Right.
They're going to be empty.
You got empty trucks, right? Exactly.
Because no one, you know, they're not gonna trust that this is something that they're not going to be taken advantage by, or being mistreated, or not compensated for, and you know, and things like that. And I think that's really important. I think, you know, thinking about caregiving, I think, you know, even the logistics of caregiving make it really difficult to seek healthcare. So even if a caregiver wanted to, you know, make their I don't know, postpartum appointment, you know, you have to think about finding childcare. You have to think about finding transportation, and it might take the whole day to get to that doctor. And just, you know, just the logistics about how our healthcare delivery system is set up to not include our, you know, multiple identities as caregivers, as mothers, as, you know, daughters or sisters or whoever we're taking care of, and not have that also facilitated for us as we seek to take care of ourselves. That is also something that is a detriment to a lot of people seeking care on a timely basis.
Yeah. And I don't want to just, I don't want this to be like a Debbie Downer type of conversation, right? Like, I don't want to just focus on deficits, because I mean, naturally, as public health practitioners, that we focus on deficits. Like, that's our job, right?
Absolutely.
So that's what we do. But I think it is key to focus on deficits when you're talking about systemic abuses, right? And inequities. Then you're talking about systems in place that are, you know, either designed to keep those inequities as they are, or to just perpetuate them, right? But on an individual level, I prefer to speak of strengths. And so I know that there are, you know, groups of women who are doing all of the positive things that we talked about, right? Who are forming spaces for other women to talk about the issues that they're having related to their healthcare, right? And are figuring out ways to get people to the doctor, and are figuring out, you know, their own interventions, right? Outside of a public health practitioner, they're figuring out their own interventions, whether it's just like a running group or a cooking group or whatever, right? Or they're figuring out ways to get each other to the doctor, even if it's just like, you go this day and I'll keep your kid, and then when I need to go, you keep my kid, you know, or I will figure out ways. Like, I've seen, you know, specifically Black masjids have those types of programming where, you know, they focus very intentionally on the health in their communities, and they figure out a way to get it done. So, you know, in the face of all of this, you know, oppression and experimentation, you know, Black women, particularly Black Muslim women, like, we've done a tremendous job maintaining the health of our communities, because we're still here, right? I mean, if that's not a testament to, you know, strength, I'm not sure what is, because we are still here. And, you know, our communities may not be thriving the way that we would ideally like them to, but they are. We figure out a way to take care of ourselves, whether it's naturopathic remedies, right? Or seeking care outside of traditional healthcare system. We figure out a way to keep ourselves healthy, or we figure out a way to stay at a base level of health. What I would like us to do is figure out a way to elevate that. Mm-hmm. So that it's not just about like maintaining, it is truly about thriving in a way that fits whatever a specific community's definition of thriving is. And, you know, to have the ability to amplify those conversations, for me, is really key. Because I know people are doing it. I would like to spotlight those things. It's important to have the historical lens, and it is very important for public health practitioners to focus on all those disparities. It is important as individuals who are interacting with the healthcare community to be aware of them, so that we could be better advocates for ourselves. But I think that, you know, we do a pretty good job in the face of everything, right? Like, against us, we do a good job. Because even when you had these conversations recently about, you know, just the astonishing levels, the Black maternal mortality levels, just astonishing rates, you know, Black women took the lead. And like, listen, we need to have these conversations, right? We need to be more actively involved. There have been reproductive justice groups, you know, for decades, but they figure out a way, you know, each time this conversation turns, to make sure they're dead center in the middle of these conversations, right? And to turn it so that you have no choice but to focus on the women that are most affected, when it comes to these conversations. And that's admirable. That's admirable work. It's hard work, but it's big work that's being done.
Yeah,
So,
and to that point, I just want to express my gratitude to you, Kamilah, for like your vision and all the work that you're doing with Community Health Compass, and in the communities that you live and work in general, and how I just want to echo how important it is to continue to uplift that work and to continue to uplift a lot of the work that has been happening for years. You know, how you mentioned the communities that kind of lead their own interventions and find the herbal remedies and the ad hoc daycares that they create, so that, you know, people can go to that kind of work needs to be uplifted as you know, community-led interventions that are actually working and succeeding and contributing to this notion of health that we all aspire to achieve. So thank you.
Absolutely. I'm doing very little compared to what is actually, you know, what's being done, you know, like nationwide. I have said before, and I will say it again unabashedly, that when you don't have to look far to see a Black Muslim woman taking the lead. Like, we are always taking the lead. Whatever type of intervention we're talking about, health related or not, you ain't gotta look far to find a Black Muslim woman who's doing the work. We just need support and amplification, and like, trust me, what benefits us in turn benefits everybody else, right? That's just how it goes. I didn't make the rules. It's just how it goes.
Well, thank you everyone for joining us for the second conversation. We look forward. We're going to be meeting again one more time to talk a little bit more and take a deeper dive onto some of these topics, and really looking really deeply at maternal and mortality outcomes for Black mothers, and kind of taking that to the next level based on this conversation.
Yes. Thank you. I appreciate having this conversation.
Thank you. Thank you for joining.
Assalamu alaikum.
Assalamu alaikum.